Hello and welcome everybody. My name is Shadi Gamal, lecturer of radio diagnosis, Cairo University School of Medicine. Me and Dr. Islam Taha are honored to welcome you in our new radiology course, which is called Radiology Reporting System. In this course, we are aiming to make everybody able to properly read or interpret imaging findings and how to write it in a proper way. And we are not focusing primarily in our course here to how the system actually works like the mainstream courses everywhere. We are just here focusing on how you open the case, how to fully read it into a proper way, giving you skills on how to see and properly identify or pick up findings, how to interpret it in the right way, and how to write it in a proper report, and how to write an opinion for a report in an actual way or a language to make the clinicians properly understand what you actually wrote, and in a proper scientific way. This course is made for everybody. I mean, starting from the residents, or just begin the residency, and senior residents, and maybe even the specialists. So you will understand what we're actually going through, or actually doing in this course when we go through our course and see how we'll bring cases, how we will teach you how to read them, how to interpret the images, how you can pick up findings, and how to write them actually, because most of us or a lot of us knows some kind of basic knowledge of the radiology, or know how the lesion looks like, and how they know how they diagnose them, but they cannot write it in the right way, or they might have some kind of a difficulty when they have a lot of workload and they don't know how to end the report in the right way. So we'll help you to get into the process of writing, and this course is made primarily for reporting, and I'm not going through systems and to classify system into like the urological module, going to the kidneys and we'll go to the ureters. No, we'll go through the examinations. I mean, we'll go through the CT UT, the CT urography, the MRI, and pelvis. We'll go through modules, of course, but we will just classify them by module, by examination types. So to make it more easy for persons dealing with the workflow in the hospitals and the radiology centers or something like that. Hope you like our course, and let's start. So I'm not a big fan of presentations or slide shows or something like that, but we have to go through some very basic things before we start anything. So before you start any examination, for writing it down or even interpreted images, you have to ask yourself a few questions, whether the proper technique is done or not, because it's very important. You cannot write any report without ensuring that you are looking at the examination which is done in the proper way, in the proper technique, because wrong technique, of course, will lead you to wrong findings, wrong interpretations, and wrong diagnosis at the end. So it's not of course, you cannot write any examination before ensuring the proper technique. In our course, we're not dealing with the proper techniques or how it is done, so you can check a lot of courses or the books how the technique is done. The second thing, and the third and the fourth, are linked together. The proper history, which is linked to the indications, and then you get the answers. So the proper history, I don't mean going to deep history details. I mean just, if you are dealing with a CT urography examination, which is our subject today, you have to ask about the actual complaint of the patient, whether like he's having a loin pain, he has an hematuria, he has renal swelling, or of course you have to ask about this time, the course of the disease, and you have to ask the onset in a brief way. So you have to link the proper history with the proper indication. So we're talking about the CT urography examination, so it's not logic that you find the patient is going through this examination, this complaining of chest symptoms. It doesn't make any sense. So you have to link the proper history with the proper indications, and then you bring the answers of this questions before you start the examination. So, going to the next slide. So, the report structure, which is our aim in this course to make you properly write the final report. This is our aim. This is the actual thing that we want you to make it in the right way. So the report structure is pretty basic. Most of us know about it. So it's easily made into, this is a skeleton of it. The title. So I'm dealing with the CT urography examination today. So the title will be CT urography, and of course CT urography is done with and without IV contrast, and we have to write it down in the title like this. So this is a basic skeleton of the report. This looks like this, and we'll go through it when we are going through a case here today. And at last, the opinion, which is the most important part of the report, which actually the language which you're trying to convey to the clinician, and what the patient actually has, or the diagnosis and the answers. When you can call it a conclusion and impression. This is a diagnosis, or in other terms, what the patient actually has. So we'll begin our first examination here in the urography module by contrast enhanced CT of urinary tract, or simply called CT urography. So this examination is basically made of two combined examinations. So the first one is the CTT, or the CT without contrast, and then the contrast enhanced part of the study when I'm going to inject the patient with IV contrast medium, and then I came up with two different sequences of images. First one, which is the venous phase or the corticomedullary phase of the kidney, and the other phase, which is called the late phase of the study. So we're basically dealing with three sequences of images. We're going through them right away. So a lot of us, especially at the beginning of our residency, we can have this, examination CT urography, and you don't know what you're actually looking at. So you have to answer some questions or look for some things before you go into the examination. So are looking for basic things. So of course, this examination is made of CTET, so we have to look for stones, and have to look for back pressure changes. I mean, the stones are causing hydronephrosis or hydroureter. And the most important indication for this study is looking for renal or ureteric or renal bladder masses. So right down here, bladder masses. This is the most important examination because most of the clinicians, request this examination to look for tumors, whether they are renal or ureteric, like urothelial tumors or bladder masses. This is the most important. So the contrast medium is, of course, important or essential to rule out any of this, because without contrast you might miss small tumors. I'm not mentioning large tumors like 4 or 5 centimeter renal masses, which can be seen in non-contrast studies, but I'm talking about small things, especially which are not exophotic. This small one is light in the cortex without causing bulges. You can miss them easily without contrast. So this is the most important indication. You have to ensure that you are looking for them. Last one is looking for ureteric and bladder filling defects. I mean, it might be stones, might be polyps, might be masses, might be anything. So this is the importance of the delayed phase of the study. And also we want to assess the renal side and the parenchyma. I mean, the shape of the kidneys and the surface of them, as well as their parenchyma, whether they are atrophied or normal. The renal perfusion, which means the degree of enhancement of the kidneys, because a lot of diseases actually cause affection of the perfusion of the kidneys, especially the vascular diseases. Excretory function of the kidney, which means the kidneys are excreting the dye which was injected by the injected contrast medium. Is it excreted properly by the kidneys or not? And of course, look at the other abnormalities. So this is our aim, to teach you how to report and describe, and most importantly, to formulate a clinician and a professional opinion for the clinician. So let's get started with a simple urographic case like here. So basically, the CT urography examination is made of simply at least 3 essential, phases. So let's begin with this. We have this, and the most left side of the screen we have this non-contrast phase. I mean with non-contrast that you cannot find any contrast medium whether inside the vessels like the aorta or inside the kidneys here. Second phase of study, which means that's the nephrographic or the corticomedullary phase of the study, which you can see the kidneys are enhanced here. But preferably, we don't want to see any kind of a dye or contrast medium inside the pelvis. This technique is not the best technique in the world, so can neglect this part. So basically, you can see the contrast medium inside the vessel, like the portal vein or the aorta or the IVC. And the last phase, which is one of the most important phases, which is a delayed phase of study, you cannot see properly any contrast or faint contrast inside the vessel, but you can clearly see the contrast inside the pelvic calcium system and the ureters, and of course, lastly, the urinary bladder. So simply, we'll begin with this non-contrast phase of the study. I must mention a very important note here that when you look at this examination, you have to look for the sequences with the largest numbers of images because it's called the source images. These source images contains the smallest thickness and the largest number of images, which helps you that you can pick up the smallest stones ever. So don't forget to look for the smallest thickness or the highest number of images, because the reconstructed images, as you can see here, contain only 89 images, which is a thicker. And you cannot miss stones big like this, but you can miss smaller stones, of course. So you have to begin your examination by looking at the largest number of images. So don't forget that CT urography is basically a CTUT plus 2 more phases. So let's begin with the CTUT here. We have to look for stones mainly here. So looking at the right kidney here, any dense structures inside the calyces or inside the pelvis, I can see nothing. So on the left kidney here, I'm looking for a dense structure. Here we can find one. This one is inside the pelvis of the kidney. So how I can be exactly sure about this? So I have to bring the first reconstructed images. Sorry, this one. And this line is just a reference line to see what the stone, where it actually lies. So it lies inside the pelvis of the left kidney. And you have to measure it in the largest axial dimensions here, because axial dimensions are the most important, because they might give you an idea whether this stone will go by itself, or it will pass, or just needs an intervention. So this is two measurements. The most important is the largest one, and second most important thing that you have to do is to measure the Hounsfield mean attenuation value. So this number here, the mean 824, is the mean attenuation value. It's important to mention, or essential to mention actually, because it's important for the clinicians to whether they might intervene by making as well. It's a prognostic value. It's prognostic importance because it tells them whether the ISWEL will actually do things or not. So I mentioned the stone, where it lies, how it measures, and what it measures, and last thing I have to mention whether it causes a dilatation or obstruction or not. So if you look carefully at the pelvic calcium system here, you can see it's comparing to the right side, it's dilated. So it's here, you can see how it's dilated here, and here we cannot see all this dilatation. We actually see the sinus fat, which is hypodense to here surrounding the pelvic calcium system. Here it's more or less effaced. You can see here the pelvis is dilated, so this stone is actually obstructing mildly the calyces, and from middle of these calyces and cause mild irritation. So I have to mention the size, the position, the size, and the location of the stone, and whether it causes back pressure or not. We'll go through this when we go into the report structure itself. So we finished the kidneys, looking for stones. Then we go to the ureter here. We go all through its course here in front of the psoas muscle. Here, don't miss it. Here, somehow it's difficult to, but here it is. And go through here and here until it enters the renal bladder. So no stones inside the right ureter. I will follow the same step on the left one here. Get it from the pelvic cell system here. This is the pelvic cell system ureteric junction, and then go to the left ureter. It lies anterior to the left psoas muscle and goes all through down. Here it is. Down. And the curve posteriorly here until here it enters the renal bladder. So no stones here. And important reconstructed images here is which is called the curved reconstruction. The importance of this image is that the operator who can draw the ureter as a reconstructed images all through from the kidneys down to the renal bladder. So you can easily spot any dense stone inside. And it's also important to delineate the dilatation of the courses of the ureter along their courses. An important mention that have to be said is that you have to carefully look at both images. You cannot account or just depend on these reconstructed images alone, because these images are operator dependent. So if the operator didn't follow the ureter properly, you might miss small stones inside in some spaces of the courses of the ureter. So you have to ensure that you have to follow the ureter course all through the source images or this sequence with the largest numbers of images. So the last thing we have to deal with is the urinary bladder. We have to look carefully for filling defects or stones or wall thickness. This is a normal thickness of the urinary bladder walls. There's no abnormalities here. So this is a basic CTUT. If you want to go through further, you have to go into the next phase of the study, which is called the venous phase or corticomedullary phase. This is important because it can clearly delineate the actual size of the kidneys, the actual parenchymal differentiation, which is made of cortex outside and medulla inside, which are the small hypodense structures inside. So you can see clearly the differentiation between attenuation of the cortex and the medulla. This is some kind of hypodense. It's called hypodense. This is normal because any blurring or any if you lost this differentiation, it's a pathology. You should know how they actually look like, and you have to make your eyes get well and get used to how they look like, because it's very important. The second thing is look for any renal masses here, any bulges, any abnormal attenuation. So I cannot find anything. So this is perfectly normal, perfectly secure for the patient, nothing. So I have to check for the vessels, renal vessels, are patent or not. So if I go to renal arteries, I'm going through the aorta, which is midline here, and we go through these vessels which arise from the aorta, which is called the renal arteries. They are patent, and I have to check for the renal vein. So if I cannot find the renal vein, I can go through the RVC, which is this structure, and you can see this vein going through the right kidney. This is the right renal vein, and of course the left renal vein here. This is variation. It's not the normal course of the vein. Of course, the left renal vein courses anterior here to the aorta, but in this case, it just curves posteriorly here. This is called retroaortic left renal vein, which is a normal anatomical variant. There's nothing of significance. So, I didn't finish my examination. I have to go through all the organs of the body here. I didn't go through them in the non-contrast phase because it's better to assess them in the pre-contrast phase. In the post-contrast phase. So looking at all the organs, spleen here, nothing of significance. Liver, looking for any focal lesions or cross abnormalities, nothing. Don't forget to check for the gallbladder here, no stones. The pancreas here, head, neck, body, and tail, nothing of significance here. And I'll go through the bowel from down here, the rectum, going through the sigmoid colon, all through, and the descending colon, splenic flexure here, and transverse colon, hepatic flexure, and lastly the cecum here. No gross abnormalities. You have to check the bowel in this systemic ways in order not to forget or miss any focal lesions inside. Of course, you have to look at the stomach, see if any abnormalities inside. Don't forget to check for the lymph nodes. When you're looking for lymph nodes, you're actually looking at the axis of the vessel, the celiac axis, mesenteric, the aorta, and the IVC, whether any rounded lymph nodes here, the common iliac veins and the arteries, nothing, no lymph nodes through the courses of the vessels all through. So you can see some contrast here inside the renal bladder, which is not perfectly well. You only want to see it in the delayed phase of the study. But anyway, nothing of importance here. So let's come to the last and most important phase, which is called the excretory phase of the study. Here you cannot see the contrast inside the vessels, but you only see them inside the kidneys here, or the pelvic cell systems, inside the ureters, and of course inside the bladder. We're actually looking for any kind of filling defects inside this contrast-filled calyces. This is normal shape of the calyces, and this is the normal shape of the cups of the calyces. This is perfectly normal. If you have a semilunar or concave shape, this is normal all through. Looking for any filling defects. These filling defects might be tumors, might be stones, might be masses, it might be anything, but you have to check that they all through nothing hyperdense inside this hyperdense contrast inside the ureters. So we have to follow them all through here in front of the psoas muscles here. Sometimes the peristaltic waves make the contrast not well opacifying the ureter, especially the right one. So don't be, deceived by this. Here it comes again. And you might ask yourself how I can be perfectly sure whether the peristalsis or not. So there's actually a lot of things. So if you're suspecting something inside this ureter, so it's more logical that you have dilatation proximal over or above it. Another thing that you have to check for the pre-contrast images here, you can find the ureters here are perfectly fine and well delineated, so you cannot see stones, you cannot see filling defect, distal to this unopacifying area. You just see the ureter as well here opacified. The peristaltic waves are responsible for this, like this. You cannot, there's no problem or whatsoever when you see this. So they have these reconstructed images like this pre-contrast one. You can make this post-contrast one, as you can see here. The calcium system here is mild dilatation because this is stone. Here it's normal. You can see this one of the spot parts because of the peristalsis, which is perfectly normal. The last thing you have to check is the renal bladder. We're looking actually for any filling defects inside the renal bladder. This is the most important thing. Bladder here is not properly filled with contrast, it's McLean with the urine, but it's okay. We're looking for any parenchymal thickness, wall thickness actually from the bladder, whether cystitis or inflammatory, no divertically, no abnormality whatsoever. So the last image we have to deal with is reconstructed images of this pelvic cell system and the ureters and the bladder, which is 3D reformatted images. You can perfectly look at the pelvic cell system here. This is a cut of the calcium, which is important from the belly and the pelvis here, and the ureters, of course. This is a part that is said that is responsible by or caused by peristalsis. It's nothing of importance. If I flip it, you can see another. It's the same image, but from a posterior point of view. This is the right kidney, the left kidney. You can see the bladder from behind, the same part of peristalsis, nothing of importance. So the only finding we have in this case is a stone which is inside the pelvis of the left renal pelvis, which is causing mild back pressure changes. So let's get through the report of the case. So beginning with the title, the CT urography examination before, I mean CTUT, and after, this is called the CT urographic examination. Begin with the most important finding. We have a stone, left renal pelvis stone, left renal, and it's like in the renal pelvis. We have to measure the most sizable, the most largest dimension of the kidneys in the axial plane. You can of course measure it in 2 axial dimensions, and the most important, we have to measure the mean attenuation. It's important for the clinicians. And then you have to say whether it causes any kind of dilatation or not. can say related mild dilatation of the left renal pelvic cyst. Here we have a note that might be said here in this case, that you might see that this ureter is mildly or slightly more dilated than the right one, which can be explained might be this obstructing stone might prevent the peristaltic waves to go through distal to the stone. So this you might mention, might not mention, because it's not very important, but most important, the dilatation proximal to the stone, not distal to the stone. Anyway, we mentioned it in this report, and we have told the clinician that there is no stones distal to this. So next step, we have to comment on the contrast excretion. I mean by this that the delayed phase of the study, both kidneys excreted as a dye injected by the IV contrast medium, and they are well concentrated. I mean, they are not diluted, no delay, no dilution, and they are showing more normal size, no duplication, no matis, no things like parenchymal necrosis or something like that, and of course no right linear back pressure changes because we have left one. And of course we'll talk about normal course and caliber of the right ureter. The left ureter we have some mild dilatation as we mentioned earlier. And last, most important thing, we have to comment on the renal bladder, that it has no stones or massive inroads to the pelvic organs. One thing that we have actually missed, that if you look carefully here, you have some kind of sign finding, which is fine renal calcification, which is not important or significant in this case. If you look at the source images, you can see it more clearly here. So it might be a sequel of prior hemorrhage or something, but it's not important in this case. So let's get back. Right adrenal calcification. So our opinion here has to be the easiest language that the clinician understand, and must be very short and very informative. The least number of words and the most meaningful words. So if I to pick the least number of words here, I will say left renal pelvic stone with mild back pressure changes. So patient understood that there's a stone obstructing the stone inside the pelvis of the left kidney and mild back pressure changes. And that's it. This is your report. I want you to know that you don't have to describe a lot in your opinion or in your report structure, because if you are trying to write a lot of words, you're actually going through a lot of putting yourself into a huge load of words, which can make you prone to easily mistake or write things that are not properly right or something. So in order to prevent yourself from falling into mistakes, especially spelling mistakes or something like that, you have to pick the fewest number of words and the most meaningful words, and without going into too much details that are not needed. So the best report, in my opinion, that has it might be concise and straightforward report without going into too much details, and answers the most important questions for the clinician. So I will leave this report as well as a normal template report in the description. Hope everybody will like the video. Please subscribe and comment. I want to know your feedback. In order to receive notification, don't forget to press the bell button. Everybody who listen to this video, I want to know your feedbacks. If anybody has any questions, don't hesitate to contact me on the Facebook page, on the YouTube page. I will leave the links below in the description. Thanks everybody, and goodbye. See you in the next video.